I'm going to get started. I should think that everyone knows who I am, but just in case you don't know who I am, I'm going to turn on my camera for a few minutes and turn it off once I start presenting. So I'm Dr. Gardner. I'm a lecturer here at the University of the West Indies, and I teach clinical medicine. And today I want to just do a brief review of a few of the neurologic topics that you may encounter in your MCQ, and certainly you will encounter in your careers. So I'm going to start off with some questions, some multiple choice questions that are, I would say, typical of the kind of multiple choice questions that you will likely see on your MCQ papers. Not to say that they are coming in the exam, because I don't set the exam, so don't get too excited about that. But they are typical questions. This is pretty much how the questions are designed, how they're structured for the MCQ. So we're going to start off with those questions, and I'm going to invite you to share your answers in the chat. This is not a test, so we don't care who answers what and who gets them right, but it will in fact help you, hopefully. So just read the questions and put your answers in the chat, and then we are going to go through the presentation and then see whether or not you want to change those answers based on the information that you've heard, or that you were right on point with your answers. So here we go. The first question. So the 23-year-old woman presented to her physician complaining that her right lower limb had become progressively stiff and clumsy over the past 2 weeks. She's worried because she has not been able to work for the past 4 days. On examination, tone is increased and there's clonus and an upgoing plantar. There is decreased sensation in the lower limbs with loss of proprioception, vibration sense, and a pale optic disc. She admits to having 2 episodes of blurred vision in the right eye within the last 2 years, each lasting for a few weeks, but she has fully recovered. Which of the following is the most appropriate initial treatment for this patient's illness? And the options are there. All right, so once I start seeing the answers coming in, I'm going to move to the next question. You usually get about 1.5 minutes to answer the questions in the MBBS based on the number of questions I see there and the time that you get to complete the paper. So it's about 1.5 minutes. So you don't want to spend more than that, certainly less, but not more than that on a question. All right, see the options coming in. All right, so we're going to move now to the next question. A 31-year-old woman presents to the internal medicine clinic with a 3-week history of progressive difficulty walking associated with lower back pain. She has difficulty climbing stairs and complains of tingling and numbness in both hands, which radiates to the elbows. These symptoms are affecting her activities of daily living. She has a past medical history of type 2 diabetes mellitus and reports recently recovering from food poisoning about 2 months ago. On examination, her vitals are normal, her cranial nerves are intact, but she has 4 minus out of 5 poor at the hips, 3 out of 5 at the ankles. She has absent sensation to pain and vibration up to the elbows in her upper limb and up to the hips in her lower limbs, absent reflexes, and no plantar response. What is the diagnosis? Options are there. The answers coming in for that one. All right. Next question. A 55-year-old male presents to the emergency room complaining of diplopia, easily tired than usual and has difficulty climbing stairs. Excuse me, easily there. He noticed that he has been having difficulty shaving his head and even brushing his teeth. On examination, his reflexes are normal throughout. Which sign or symptom is most indicative of myasthenia gravis? All right, answers coming in there. So next question. We have a couple questions. Well, I don't remember how many I have here. A 33-year-old female presents with drooping of her eyelid that seems to occur while reading or watching television. And I hear some people say, oh, I know what the answer is. This appears to get worse later in the day. She also reports that at times she sees double. A few weeks ago, she was prescribed an antibiotic medication for urinary tract infection. She does not recall the name of the antibiotics. On physical exam, bilateral ptosis with the left affected more than the right is seen. Pupillary function is intact. A glove is filled with ice and subsequently applied to the patient's eyelid. After 2 minutes, the patient's ptosis has improved. Which of the following is most likely to yield rapid symptom improvement? All right. Next question. A 38-year-old female presents with muscle fatigue that is worse by the end of the day. She reports having myalgias in the back of her neck and at times her head drops. She has also started seeing double when watching television or reading for a prolonged period of time. On physical examination, ptosis is produced when asking the patient to look at the ceiling without blinking. Pupillary function is intact. Appropriate serological test is obtained. On repetitive nerve stimulation, the amplitude of the compound muscle action potential progressively declines. Which of the following is the most likely diagnosis? All right. Next question. A previously healthy 26-year-old male is brought to the emergency department due to muscle weakness. He reports mild weakness in his legs that has progressively worsened over a few days to the point that he can barely move his legs. He has some numbness in his legs and his arms feel weak. He has recently recovered from a respiratory infection. 1 out of 5 muscle strength is noted throughout the lower limbs as well as absent patellar and ankle reflexes. 3 to 4 minus out of 5 muscle strength is appreciated throughout his upper limbs. A lumbar puncture is performed, which shows the following. Say cell count in the CSF is 4 cells per millimeter cube. Glucose is 67 milligrams per deciliter. Protein 187 milligrams per deciliter. Gram stain, no organisms. Oh, I'm supposed to put the normal values here for you. So for the cell count, it should be 0 to 5 cells per millimeter cube is the normal. For the glucose, what was it? This is normal glucose. I think it goes up to 90. And for the protein, this is high protein value there. And for the other things, and the forced vital capacity, here is 0.85, normal being 4.8 liters. All right, so that was supposed to be the question. All right, so go ahead and choose your answers. Okay. All right. Everybody should try and participate, you know, so put your answers down and see what you get. All right, I'm almost at the end as it relates to the questions. A 30-year-old female presents with muscle weakness in the lower extremities and palpitations. Her symptoms have been progressively worse over the course of 2 weeks. She reports to be in great health, but had a period of abdominal pain and diarrhea approximately 5 weeks ago. Her temperature is 98.9 degrees Fahrenheit. Blood pressure is 117/82, pulse 102 per minute, and respirations are 116 per minute. On physical exam, there is a 4-5 muscle strength throughout the lower extremities, bilateral patellar reflexes 1+, and angular reflexes are absent. Lumbar puncture was performed and the results are pending. What is the most likely diagnosis? We have a part 2 to that question. What is the most appropriate initial treatment? All right, great. And this is the final question. A 44-year-old female presents with weakness. Her weakness becomes apparent when she picks up her youngest daughter or when placing her non-perishable foods in the top shelf of her kitchen. She also reports difficulty with getting up from a chair. The symptoms began a few months ago and have since worsened. On physical exam, there is an erythematous eruption on her eyelids, and erythematous papules on the dorsal aspect of her hands. Neurological examination is significant for symmetric muscle weakness of her shoulders and hips. Which of the following is most likely the diagnosis? All right, so those are the questions. So what I'm going to do now is I'm just going to go through some of the neurological conditions that you may encounter, as I said before. And the first one that we'll look at is TSP, or ham, tropical spastic paraparesis, or HTLV1 associated myelopathy. This particular condition, it seems some persons, even those who've trained, that you have never heard of it, which is quite unusual, because a lot of work has been done on this particular condition, right? Here at the University of the West Indies by our late Professor Hanchard and the late Professor Morgan. So you look in literature, you'll find papers written by them in collaboration with other researchers. Also papers coming out of Japan as well. So we really can't be in the Caribbean and attending a Caribbean medical school, and we really don't know about TSP or ham. Now, it is not as common as it was before. Mind you, it's not a very common condition. It really affects maybe about 1 to 4% of people who are infected with HTLV1, and the lifetime risk is really small, less than 2%. So it's not a common condition, but it has been described in our region. So, and work has been done on this particular condition in our region. So you can't be a Caribbean physician and not know what TSP is and not know what it looks like, right? So as you see, there is a myelopathy that is associated with HTLV1, but there are some cases of HTLV1 negative TSP or ham, which you can imagine is much more difficult to diagnose because the condition is mostly diagnosed clinically. And the areas that you'll find is in, as I mentioned, the Caribbean and Southern Japan and Asian countries. Is perhaps where you will likely see this condition. The incubation period ranges from months to many years. The affects mostly females, and certainly I've seen mostly females affected with this condition than males. Tends to occur in the 30s, 40s, 40 years, but not to say older persons can in fact present with this condition as well. And so it should be, once a person meets the physical presentation, it should be something that is on the differential list. So it's associated with HTLV1. And as I mentioned before, just about 1 to 4% of persons are infected with HTLV1 develops this condition. Lifetime risk is less than 2%. Pathogenesis, and this is just really here for completion, is not to say that this is something you have to memorize or anyone will particularly ask you about this. just to give a brief overview, and just completing a presentation of the pathogenesis of this condition. Really, what happens is that the HDLV1 infects the CD4 cells, which then finds their way into the central nervous system. And when it's there, it stimulates other inflammatory cells to start an inflammatory cascade, as it were. And this leads to expansion of immunocompetent T cells directed against the virus. So there are more cells that are now seen in the CNS, in that space, stimulating more inflammation, resulting in damage of CNS tissues. And subsequently, what will happen is that the inflammation continues, it becomes less cellular and becomes more atrophic, as tends to occur with inflammation generally. So you have chronic meningomyelitis of the white and gray matter. Axonal degeneration happens, preferentially affecting the middle to lower thoracic cord. Hence why the presentation is what it is. A correlation between a high proviral load in the CSF and peripheral blood and symptom severity has been found. So the higher the viral load, it is thought, it would appear that it affects the severity of the symptoms that the patients will present with. Now, this is something that you want to pay attention to as it relates to this particular disease, and in the disease in general, as we go through them, is how they present. If you look at how the questions were set just now, a lot of them had in there the presentation, how the patient presented, what findings that you obtained from after examining the patients, and using that as means by which to go ahead and make a diagnosis or to initiate treatment. So it's gradual and slow in onset, so much so that the patients will not necessarily present initially. They'll actually present at a much later stage, because initially they will think, oh, it's nothing, it's just a little cramp in my legs and so on. And for the patients I have seen, certainly this is how they present, or they may have been to many doctors for these symptoms, who tell them that it might be arthritis and so on, until their symptoms much later, their symptoms starting to get worse. It affects may get back pain, paresthesia, impairment of urinary bowel function, erectile dysfunction, increased urinary frequency, urinary retention, and it is also HDLV1 is also associated with dermatitis and also psoriasis as well. So the spastic paraparesis, or paraplegia with hyperreflexia. So the person will have upper motor neuron findings when you examine them, and you'll find that the weakness is mostly proximal weakness that you'll find in these patients, which is a unique presentation here, because it's a spinal cord lesion, which tends to have more weakness distally than proximal. But in this particular condition, the weakness is more proximal. And the patient will have decreased touch and pinprick sensation in poorly defined thoracic areas. Vibration, in other words, there is no sensory level. Vibration sensation is impaired in the lower limbs. They may get hyperreflexia in the upper extremities, but often when you're getting findings in the upper extremities, you may want to consider that there may be an associated or additional pathology, perhaps cervical spondylosis as well in these particular patients, because generally they may not get hyperreflexia, and generally the upper limbs tend to be relatively normal. They may get several signs or may not, and optic neuritis is very rare in these patients. In fact, I've never seen any patient that I've seen with TSP having optic neuritis. So that's very, very rare. In fact, if I see a patient presenting with low limb weakness with optic neuritis, my first thought will not be TSP, but would definitely be something like MS or NMO spectrum disorder. And this patient tends to have a scissors gait because of the weakness of the proximal muscles. So what are the investigations you want to be doing? You want to, of course, do the serum HDLV1 antibody. You may want to do CSF, lumbar puncture, to analyze CSF. Often this is not done. Often when it is done, it's perhaps because you want to rule out other possibilities in terms of diagnosis. But if it is done, these are some of the things that you will see: pleocytosis, increase in white cells. You may see increased protein, as well as you will see with any pretty much CNS inflammation. Protein levels will in fact go up. And you may, in fact, get antibodies to HDLV1 in the CSF if you are able to test for it. The imaging often not done again to diagnose the condition, but done to rule out possibilities of spinal cord compression or other disease affecting the spinal cord. So you may do an MRI of the thoracic spine or thoracolumbar spine. And you may or may not see cord swelling or atrophy. Like I said, when you're doing the MRI, you're not necessarily doing it to diagnose the condition, but to rule out the possibilities, other possibilities. Because the diagnosis is largely a diagnosis of clinical diagnosis. So how do we treat these patients? Well, it's symptomatic. There is no cure. So once the patient develops TSP or HAM, there is no going back. There's no way to fix that, right? The symptoms progress, and that's just how it is. And we are now left as physicians to manage the patient symptomatically. And what is not here on the screen is that these patients may also become depressed. So, excuse me, they may also have to get psychological or psychiatric evaluation and treatment, but that becomes a part of supportive care. But symptomatic treatment, so analgesics, so often the analgesics that we may offer these patients are the anti-epileptics such as pregabalin or mirobalin, maybe given to gabapentin, maybe given to these patients because they tend to have neuropathic type pain. They may get antispastic medication because of this significant spasticity. That's one of the marked features of this condition. They're quite spastic. So baclofen is often used in our setting, but you have others such as tizanidine, is also another antispasmodic that may be used as well. Some persons may use benzodiazepines. Antibiotics may be given. Of course, this is given on a needs basis. So these patients tend to get recurrent urinary tract infections, and so we may have to be treating infections repeatedly. They may have to do in and out catheterization to relieve the bladder retention. They may get infected, the cubitus ulcers as well. So those are some of the complications that we'll have to look out for and be ready to manage. And physical therapy is largely to help with the patient moving around with mobility aids. Some patients may move from using a walker to using a wheelchair, and they maybe have to be taught how to use these various modalities to get around. Right. So that is a TSP in a nutshell. Multiple sclerosis. Now, multiple sclerosis, an immune-mediated inflammatory disease that attacks myelinated axons in the CSF, destroying myelin and the axon in variable degrees. And we have this condition, of course, in our population. We often diagnose more NMO spectrum disorder, which involves transverse myelitis or optic neuritis. We tend to see that more in our population. However, multiple sclerosis is also seen in our population, just to highlight that. Symptomatic episodes are separated in time and space, right? So what do I mean by that? That the patients may have symptoms that are separated by time. So they may have sudden loss of vision, painless loss of vision in the right eye 3 years ago. And then within that 3 years ago, maybe 6 months after that first episode, they have another sudden loss of vision, and they may be the same right eye as well. But then it resolved on its own, and they were fine after that, and there was no investigation, didn't bother to go to the doctor or anything, because it went back to normal. And now the patient is not presenting with weakness in the left upper limb, or left hemiparesis or something of that sort. So the symptoms are in that way are separated in time and in space. Is that it was a vision loss before, but now the patient is presenting with limb weakness. So that's space. So that tends to, when you see a presentation like that or hear a presentation like that, multiple sclerosis should come to mind, which is different from NMO spectrum disorder, which tends to be, once symptoms start, they tend to progress, right? They don't have a relapsing, remitting kind of pattern, which with that you will see with multiple sclerosis, excuse me. The duration of the attack should be longer than 24 hours. So when you're considering making a diagnosis in these patients, you want to consider how long did the patient have the attack for. So the loss of vision, how long did it last for? And the criteria here is that it must be longer than 24 hours. They should have sensory loss. They may have spinal cord symptoms as well. So they may not present with the spinal cord symptoms. As I mentioned, symptoms may be separated in space and time. So they will have vision loss on one occasion and then have the weakness on another occasion. But the spinal cord symptoms may include motor. They may have muscle cramping, secondary to spasticity. They may have autonomic dysfunctions like bladder, urinary retention, constipation, and they may have sexual dysfunction as well. Because again, it's spinal cord that tends to be affected. So the brain and the spinal cord, it's the central nervous system that is being affected. So symptoms related to diseases affecting the central nervous system is what the patients will present with. They may also present with several symptoms as well. Excuse me. Like a triad of dysarthria, ataxia, and tremor. So you may see that in these patients as well. I can't say I really commonly see this in persons who have multiple sclerosis, but it is one of the symptoms that you may want to look out for as well. Optic neuritis for certain is one of the common things that patients will present with this particular condition. Trigeminal neuralgia they may have, and not don't commonly see that. Facial myokymia as well, and not don't commonly see that where you have these abnormal twitching movements affecting the muscles of the face, and they may have heat intolerance as well. They be seen not as common as the other symptoms. Constitutional symptoms, weight loss, and so on, the patients may have those, and they'll definitely have pain. Subjective cognitive difficulties with regard to attention span, concentration, memory, and judgment. So you definitely see patients presenting with these kind of symptoms as well. And they may have depression. And depression may not so much be because of the disease effects itself, as that would be related to these higher mental function dysfunction, but because of the fact that it's a debilitating condition and it robs you of your life. So patients will and can become depressed, right? So patient physical examination, patient will have, you will find weakness. When you examine the patient, you will find they have bilateral lower limb weakness, or a person may have an upper limb weakness and lower limb weakness that may be quadriplegic as well. So the symptoms will vary, and the severity also varies among patients as well. The patient will have sensory deficits, tend not to have a sensory level, or they may generally they can have a transverse myelitis as well. But generally transverse myelitis tends to be more associated with animal spectrum disorder. They may have hyperactive reflexes. They may have a positive Babinski sign. They may have increased tone. Based on clinical presentation, including the frequency of clinical relapses. So these conditions may be classified as remitting, relapsing, which is the most common presentation, or relapsing remitting, right? Approximately 85% of cases will be like that. So the symptoms will go up and down, right? So they start off with the symptoms particular way. So they start with it, right? So a lot of times patients will present that way, where they start with the eyes, the optic neuritis, and the symptoms resolve or they improve, right? So they remit, and then it comes again, the relapse. So you have a relapsing, remitting kind of pattern, and most of the patients present that way. In fact, certainly most of the patients I've seen tend to present that way. And you have the primary progressive, which tend to start with the symptoms, and the symptoms will gradually progress. So they will not have the relapsing, remitting kind of pattern. And as I mentioned, with animal spectrum disorder, it tends to be a progressive condition, not a relapsing, remitting. But then you have MS that is similar in that regard, where you can have a type of MS where it is more primary progressive. And then you have the secondary progressive, where it starts off as relapsing, remitting, and then it just stops remitting and then it just progresses. So you have, but most cases, definitely that you will come across is relapsing, remitting type of MS. And again, now this is the McDonald's criteria, not for you to memorize, but certainly for you to be aware of. And it just talks about how you go about diagnosing this particular condition. And it is a clinical diagnosis, of course, clinical with, of course, investigative support. MRI findings and so on, but the diagnosis can be made in isolation then, so to speak. And so the McDonald's criteria is what is used to help in making the diagnosis. This is good to know this, but not memorize it necessarily. It may be a question. It could be a question. They may ask what's the common type of presentation, or you may see it in an MCQ where they are describing the presentation. I think one of the questions were like that, where it's describing the presentation. So the patient reported having some symptoms a year ago and of vision loss and a complete results, and then so that is the presentation. All right, and so for that reason, we good to be aware of this McDonald's criteria and understand what it is about. All right, things in the McDonald's criteria apart from the symptom presentation, there is the 1 year of disability progression, retrospectively or prospectively determined, independent of clinical relapse, plus 2 of the following criteria. So the person has, this is table 2, we are looking at the diagnostic criteria from this perspective, where the person has at least a year of disability, where the symptoms are progressing, plus they may have 1 or more, because sometimes these conditions are not diagnosed right away. They are missed because for one reason or another, the physician might not be aware of the condition, they may not be familiar with the condition, they're not familiar with criteria of the condition, of diagnosing the condition, and so they go undiagnosed. And sometimes the patients also present late, especially if it's a relapsing remitting kind of pattern that they have, right? 1 or more T2 hyperintense lesions. So this is good to know as well, because when MRI is done, these are the things that they are looking for and being reported on. Characteristic of multiple sclerosis in 1 or more of the following brain regions: the periventricular, cortical, or juxtacortical, or inferotemporal. So these are the areas where these type T2 hyperintense lesions tend to be found in patients who have multiple sclerosis. 2 or more T2 hyperintense lesions in the spinal cord. So you may also see these lesions in the spinal cord. So if you have the top 1 plus 2 of this, then you will be thought that you can safely make the diagnosis of multiple sclerosis. On the final one in this section here is the presence of CSF-specific oligoclonal bands. So when a CSF is done, you will find oligoclonal bands in these patients. So again, nothing I say cannot make diagnosis in isolation. So a number of these is a criteria that is being used to make the diagnosis. Right? And pathophysiology, again, just for completion and try to be aware, it has to do with the inflammatory markers or inflammatory cells getting into the CSF and causing and stimulating and triggering inflammation, which leads to CNS tissue damage and neurological dysfunction. And generally it is thought that it starts here. And I say it is thought because still experts and non-researchers have not been able to pinpoint a reason why someone will develop multiple sclerosis. Because and this is so with a lot of autoimmune diseases. And if you read literature on any autoimmune disease, you'll find that they have these 3 things here at the top as triggers for the development of autoimmune disease, but they really don't know, right? So genetic factors, environmental factors, and infectious triggers. Infectious triggers is what we do definitely see for sure. And of course, genetic factors, you can appreciate that genetics, if you have in your family, you may be more predisposed to developing a particular disease than others who do not have it in the family. But then, of course, it can be quite sporadic, right? And then hence why you see here in terms of the triggers, 3 different things being listed as possibilities for triggering this condition. For persons who've never had anyone in their families with this condition, just presents with this condition. So environmental factors are thought to play a role, and certainly infections are thought to play a role. That we definitely see. So investigations. All right, so blood investigations you want to do, you have a complete blood count looking for infections. They want to identify does this patient present with any kind of infection. So those are blood investigations you want to do. Depending on how the patient is presenting will determine what kind of blood investigations you will do in these patients, right? As I list there, don't rule out other causes of presentation. So with any patient, and this goes for any condition or any case that you will see as a physician, is how is your patient presenting? So what am I going to lead me to do? So you don't do all the things listed in the book, and keep saying, I hate this term, query. It does not do anything, because it tells you I don't know what is wrong, and therefore you're going to do absolutely nothing, or you're going to do nonsense. So you want to be able to hear the history, as we talk about just now, and be able to kind of zone in a few differential diagnoses. What are the possibilities here? And then investigate in that regard. So B12 deficiency is a reasonable possibility. So you may want to check that. Does the patient history support this? Is the patient a vegan? And we have seen that. We have seen a case where a patient actually presents with these symptoms that I described to you just now with multiple sclerosis. And the differential diagnosis of B12 deficiency was entertained. B12 levels were checked, and the patient actually had a concomitant B12 deficiency, because all her symptoms could be explained by the B12 deficiency. So it found that she had two conditions presenting. So, but could have been B12 deficiency. B12 deficiency will present with body weakness. They will present with sensory deficit as well. But when you do the MRI, you really shouldn't see anything on the MRI if the person has B12 deficiency. So when her MRI was done, she had hyperintense lesions in her spinal cord and her brain. So that cannot be attributed to B12 deficiency. So, different investigation is going to be guided by your differential what is happening to the patient. Collagen vascular screen, these patients can have a systemic lupus erythematosus, and those patients may have, in fact, transverse myelitis. Maybe seen in these particular patients. Persons can have sarcoidosis, and CNS sarcoidosis may present with lower limb weakness as well. In other infections, so syphilis, patients will present with lower limb weakness, but of course, how do these patients present is going to be different, and so you're going to be looking for those differences. If it's an older patient, you want to definitely check for VDRL, HIV myelopathy can definitely present with lower limb weakness, right? But of course, you're going to be looking at that. That is why you have criteria for making the diagnosis, and that is why you want to look at presentation. How is the patient presenting? How do these patients normally present? And sometimes they do overlap because it's affecting the same place. It's affecting the central nervous system. So some of the symptoms are going to overlap, right? So your history there is going to be very, very helpful. Wilson's disease, the way present is not a very common thing that we see in our population. It certainly is not something that's very common, but that's something to bear in the back of your mind. And if your history is supporting, then you want to consider B12 deficiency. And we mentioned about an aquaporin 4 antibody. What is that? So you hear me talk about the transverse myelitis. These conditions, NMO spectrum disorder, multiple sclerosis, are very, very, very closely related. And often for years, in fact, there have been patients who were diagnosed, and this is not just in the Caribbean, but even in the first world, what they call first world, been diagnosed with multiple sclerosis who actually have NMO spectrum disorder. And how did they find that out? Well, they found that out because subsequently, when they recognized what was involved in the development of NMO spectrum disorder, that was the antibodies against aquaporin 4 antibodies. And so they start testing for this antibody, and they recognize that it is the antibody. If this antibody is positive, it is very highly likely that you have NMO spectrum disorder as opposed to multiple sclerosis, right? And so this is something that you want to do with the presence of NMO aquaporin 4 antibody. You are likely dealing with NMO spectrum disorder as opposed to multiple sclerosis. So the patients do present very similarly. Again, history is also useful as well. Talk about the relapsing remitting type of MS. But remember, that's 85%. Most patients present that way, but you have some patients who just present with primary progressive. So history and present and examination and observing presentation is very important. But those are investigations you want to do. Continuing investigation, you also want to be doing the MRI for certain for these patients. But again, as I mentioned, not a standalone for diagnosis. Imaging procedure of choice for confirming MS and is monitoring disease progression in the brain and the spinal cord. Lumbar puncture will tend to be done as well and is evaluated for oligoclonal bands and intrathecal IgG production as well. Right, so how do we treat this? Okay, so treatment, immunomodulatory. So it's really about trying to limit reducing the inflammation. and you want to start with beta-prednisone. Beta-prednisone, the patient presents acutely. Your aim is to get that inflammation settled down. And so you will initiate methylprednisone therapy in these patients. Plasma exchange as well may be done, removing the autoantibodies. That's the idea of moving autoantibodies from the patient's serum to reduce, again, the inflammation. And this can be done, tend to be done in very acute setting as well. And we want to see rapid response or rapid improvement. The plasma exchange may be done. We of course, don't do this. I would say I would not say it's never been done at the University of the West Indies. It has been. We've had plasma exchange machine. We've had it done. But I'm not certain where that is right now in terms of use. I don't believe I've seen it used in recent time, but it has been done at our institution. So it's something that is available, not widely, but available in our setting, of course. But that's something that is done. It's probably done mostly more in the first world than here. Interferon beta, natalizumab. Those are other, it's a monoclonal antibody that is being used, and there are other monoclonals that have been developed as time progresses to treat this particular condition. Of course, this is quite expensive, and so oftentimes it is actually not given, particularly in our setting, because it's quite expensive. Again, treatment symptomatic. So we can't ignore the patient's symptoms. So it also aims to treat the patient's symptoms as well. Sometimes there is quite significant pain. So again, we try to give tricyclic antidepressant, things like amitriptyline may be used. We may use, again, pregabalin, gabapentin may be used as well for this kind of neuropathic pain, spasticity, same baclofen or tizanidine may be used as well, and they will have sexual dysfunction. And depending on the patient that you have, you may want to offer them sildenafil. But that may be an option for some patients. And the final one that I'll talk about is myasthenia gravis. Now, myasthenia gravis, and a lot of the questions I gave you had a lot to do with myasthenia gravis. An autoimmune disorder which antibodies form against acetylcholine nicotinic postsynaptic receptors at the neuromuscular junction of skeletal muscles. Myasthenia gravis is a disease. They like to come in multiple choice questions because I don't know. I guess it's not uncommon in our population at all. And I've seen physicians miss myasthenia gravis. I have missed it too. So it's not that to say that they don't know what they're doing, but you really have to be looking for this condition. There should be a routine mind. You know, when the patient presents, and sometimes they don't present typically. So I noticed some persons are choosing things like diplopia, or for some of the answers there, sometimes that's the only thing the patient presents with is diplopia. There's nothing else. And then, you know, you have to be having this, if you have to have it in the forefront of your mind, or else you just miss it. I've had patients who present with doing a myriad of, they had no diplopia, no limb weakness, all they had was this dysarthria. And the dysarthria started to progress. And so the initial thought to be stroke, they did a CT scan, they did a CT scan of the neck, CT scan of this, and they can't find what's wrong with the patient. Because of course that's not so bad, gravis is diagnosed clinically. So unless the person has a thymoma, and even then some persons may not make the connection. Right? So it's autoimmune. The nicotinic receptors, postsynaptic receptors, are the targets here of this autoimmune disease. And therefore, it gives rise to the symptoms that we see. The usual initial complaint is a specific muscle weakness rather than generalized weakness. So sometimes patients will just present with a particular weakness, as I mentioned. So it's diplopia, so it's the eye muscles, or it's dysarthria, so it's the muscles that have to do with speech. Sorry, or with breathing. Some persons present with shortness of breath, or they may present with limb weakness. I had a patient who presents with hemiparesis and facial weakness, and the patient actually was diagnosed with a stroke. But subsequently, the other weakness, the other muscle groups now started becoming weak. I realized that we're now dealing with a stroke here. This person has myasthenia gravis. So there are different muscle groups weakness that the patient will present with, and it's something to be looking out for. Extraocular muscle weakness or ptosis is present initially in 60%, so it's only in 50% of patients that you will see ptosis in, and occurs during the course of the illness in 90% of patients. So the patient actually may not present with ptosis, but subsequently most patients will have ptosis. This disease remains exclusively ocular in only 16% of patients, and I've seen patients with only ocular symptoms, only. They have no limb weakness at all, no dysarthria, nothing, just the ocular symptoms. You have bulbar muscle weakness now. It's also common along with weakness of the head extension and flexion. You have limb weakness may be more severe proximally than distally. So that's one of the things that you notice in myasthenia gravis, is that they tend to have more proximal weakness than distal. Not to say they don't have distal weakness. Remember, the weakness affects all striated muscle groups. So they will have weakness generally, but you'll find that and especially when they're initially presenting, they'll talk about weakness, proximal muscle weakness, can't get up from squatting, can't hold their hands up, difficult combing the hair and lifting up a child or so on, because their proximal muscle groups are weak. So they may start that way, but they'll subsequently have weakness in the other muscle groups as well. Weakness is typically least severe in the morning and worsens as the day progresses. Now, if you hear that anywhere, even in your deepest sleep, you must think myasthenia gravis. Right? So the patient starts off strong, but as the day progresses, so as there is more stimulation, they get weaker. And the weakness is increased by exertion, alleviated by rest. Myasthenia gravis. Less often symptoms may remain limited to the extraocular and eyelid muscles for years. And that is true. Right? So hallmark of myasthenia gravis is start strong, get weak. That's hallmark of myasthenia gravis. Weakness can be present in a variety of different muscles and usually proximal and symmetric. Sensory examination and deep tendon reflexes tend to be normal. So usually these patients, when they do their reflexes, they have normal reflexes and just weakness. However, persons who are severely weak, they may actually not have reflexes because their muscles are so weak and respond. So the weakness of the facial muscles is almost always present. So they may also have a facial weakness, so usually bilateral. Okay, I mentioned it. Their weakness produces a mask-like face with ptosis and a horizontal smile. Right? Weakness of the palatal muscles can result in a nasal twang to the voice and nasal regurgitation of food. Chewing, and if you've ever seen or heard anybody with myasthenia gravis speak, you will know that's true. Chewing may become difficult and swallowing becomes difficult. They aspirate, they have difficulty breathing, they have CO2 retention. And, some persons may not realize, some persons, in one particular case, I have a patient who was confused. He had limb weakness and so on, but was being treated for something else. And then he became confused. They couldn't understand why. When these ABG was he had significant CO2 retention, turned out his chest muscles are becoming weak. He was not able to breathe well. And so sometimes that the patient will present that that's a clue as well. As swallowing may become difficult and aspiration may occur with fluids and so on. Weakness of the neck muscles is common. So the person can't lift their head up. I remember a case where a patient present after being attacked by her spouse. And she came to hospital because she was attacked by her spouse and she was having neck pain or something of the sort. The spouse, I think, was trying to strangle her. So she was subsequently admitted to the ENT. And ENT, they didn't think there was anything wrong with her airway and so on. So they asked most medicine to see. But they were suspicious that something else was going on. Of course, initially I didn't think anything of it. I mean, her spouse was trying to kill her here. I mean, it just from that attack that she was having those symptoms. But that was not the case. When the consultant came to review the neurologist came to review the patient and asked the patient to lift the head up off the bed, the patient could not do it. And she had significant weakness. Again, it was so coincidental that the patient was attacked at the same time by her spouse, and she actually has these symptoms of myasthenia gravis at the same time. So again, just having a high suspicion, just paying keen attention will help to diagnose this condition. So we'll talk about the weakness of the neck extension flexors. Again, pathophys, and I did probably can't see this very well because I even can't see it very well. I said small. It's just giving again an overview of the pathophysiology and what happens And it's important for you to know really it's a neuromuscular junction disease. That is really what it is. And what happens at neuromuscular junction is that the acetylcholine receptors are targeted by these antibodies and they are destroyed. And so because there are fewer, when the acetylcholine comes to the neuromuscular junction, there's not many receptors to receive them. And so the muscle gets weak. And of course, the more activities that you do, then the weaker you're going to get because you don't have enough receptors to receive the acetylcholine. And so the person gets progressively weak. So the less activity you do, then, the stronger you are because the small number of receptors that are there are able to, manage and maintain you at that stage. But once you start becoming active, then you become progressively weak. So that's pretty much what this slide is talking about there. Now, there are various antibodies that these patients you may find in these particular patients, right? And these are some that I mentioned here. And the acetylcholine receptor antibody is definitely top of the list that you will see in these patients. 90% of patients with this antibody will have generalized myasthenia. And generalized myasthenia meaning that, just have ocular symptoms, but you have, or signs, but you also have limb weakness as well. Generalized myasthenia. Now, anti-smooth muscle antibodies in 80% of patients, especially patients who may have a thymoma. All right, and who are younger than 40 years old. The anti-muscle antibody is also another type of antibody that you will see in myasthenia gravis, and this one you tend to see in persons who have the ocular myasthenia. Right, you have the anti-striational antibody as well, not done as commonly as the first two. First three. Mostly the anti-muscle and the anticholinergic receptor is done. And you have the anti-LRP4 antibody. Also, that may be not done as commonly as the top three there. Thyroid function test, a good test to do. Why? So you have to consider again differentials of myasthenia gravis, differential diagnosis, and a lot of conditions, a number of conditions present similarly to patients who have myasthenia gravis. Stroke is one such. So you're gonna brainstem stroke, and we've had patients presenting with a brainstem stroke without having myasthenia gravis, so subsequently found to have brainstem stroke because they have ptosis and they have limb weakness. But then when you do the scan and you take the history, you realize it's very acute. Myasthenia tend not to be as acute, tend to be a more longer period over time progressing, right? So those are some of the things in history. History helps you a lot with these kind of conditions, helping you to diagnose them because they affect the nervous system at various levels. And that helps you too. Sometimes symptoms overlap, right? Thyroid function, because persons with thyroid disease may present with proximal weakness. And I've had patients who have thyroid disease who the physician did not know what was wrong with them. Okay, but the symptoms in my head were kind of just very florid. Like thyroid is the first thing that come to mind. But again, if you're not thinking about it, you will just miss it. And that's something to be mindful of. Thyroid function. So you want to do a thyroid function test because a proximal muscle weakness is something that the patient will present with. Right? They usually don't have the other things, right? Such as the bulbar signs or the ptosis, but then they will have the limb weakness and they'll have the proximal muscle weakness. They tend not to have the fatigability. That's also something that you can use to help as well. But it's something else you also want to do to rule that out. Want to do autoimmune screen checking for other autoimmune diseases. Because one autoimmune disease begets another autoimmune disease. Some persons have one autoimmune disease and they may present with one first, but they have another autoimmune disease on board. Other things we consider is polymyositis and dermatomyositis. Dermatomyositis, as the name suggests, will tend to have features with skin lesions. So that's one is kind of more a little easier to rule out because you tend to have the skin lesions. If you don't have the skin lesions, don't be considering that as your top of your differential list. But polymyositis is something you want to consider because polymyositis will have no skin lesions, but they'll have the proximal muscle weakness. One of the things that polymyositis persons will have too is that they will tend to have tender muscles, but it doesn't absolutely have to be tender, yes? So some of the things to consider and think about. Right, so what do you want to do? Other imaging, other investigations. So imaging CT chest. I want to do a CT chest because I want to rule out a thymoma. If the person has a thymoma, they remove the thymoma, these persons can be cured because it's thought that the antibodies are being produced there. Right? Rapid nerve stimulation. Important thing to note. Rapid nerve stimulation is one of the ways that you differentiate myasthenia gravis from a number of other things that can present similarly as myasthenia gravis. Lambert-Eaton myasthenic syndrome or Lambert-Eaton syndrome is one of those conditions that represent just like myasthenia gravis. But what will separate it is the fatigability. That condition actually, in that condition, the patient actually gets stronger with activity, right? Because you have more calcium being produced, because in that condition, it's the calcium receptors that have been affected, right? So the person gets stronger with Lambert-Eaton syndrome as opposed to myasthenia gravis. So that's one of the ways to differentiate and separate those two conditions. So rapid nerve stimulation is one of the ways that you diagnose myasthenia gravis. And with rapid nerve stimulation, you're finding that the amplitude of the nerve impulse gets less and less and less as the nerve is being stimulated, right? Anticholinergic tests, they will call it tensilon tests. Eutrophonium is being used, and if you give this, the patient will get stronger for a brief period of time, because it's supposed to be a small dose, and you want to, of course, make sure that this test can be risky. So you want to make sure it's done in a controlled condition situation. It's not often done, certainly not in our setting. I've not seen it done rarely, maybe once, if ever, if I can recall. But it's a test that can be used. A tensilon test, it is called, and evaluate the weakness in an involved group of muscles before and after administration of eutrophonium. So oftentimes what it uses is the person has ptosis, that's the muscle group that is used, the eye muscles. So you observe the ptosis, so you do the eutrophonium and observe, does the weakness resolve, does the ptosis resolve? And if that's the case, then you have a diagnosis of myasthenia gravis. But only in myasthenia gravis that's going to be happening. The ice pack test, and one of the questions mentioned this ice pack test. Now, the ice pack test is thought that when you apply ice to the area, it probably deactivates the enzyme that breaks down acetylcholine, and therefore makes more acetylcholine available at the site, and therefore resolve the ptosis. In this case, but usually it's put over the eyelid, and it's put there for about 2 minutes, and then you remove it, and then your ptosis should resolve. And if you see that, likely myasthenia or the diplopia will resolve. All right, so anticholinesterase, pyridostigmine or mestinon is what is often used in these patients. It's first line. Then you will want to also add on immunosuppressants long term. Steroids may be used initially as well, but you don't want to use steroids for long term either. Again, patient based, depending on how the patient is, and a small dose of steroid may be given along with the anticholinesterase medication, and observe for patients improvement. The azathioprine may be subsequently added while you taper off the steroids. Some persons do well only on the pyridostigmine or on the anticholinesterase inhibitors, and don't need no need for steroids after the initial treatment with steroids. Some persons will need MMF or cyclosporine. They have the plasmapheresis also may be done in these patients, again, because it's autoantibodies. So I thought that removing the autoantibodies in these patients you'll get rapid improvement, and it, in fact, like I said, is mostly done in first world, not here often. IVIG may be done. It's typically used for myasthenic crisis, though, or for those persons who are refractory cases, right? Excuse me. So the IVIG can also be used in myasthenia gravis. Often not used here, but certainly in person myasthenic crisis, you may want to use it. That, and also similarly with plasmapheresis, those who are presented acutely and severe. Surgery, thymectomy for all patients with thymoma, or those 10 to 55 years with no thymoma with generalized myasthenia gravis. So those are the persons you may want to consider thymectomy in. Oh, I said myasthenia was the last thing. Well, it's GBS, I think it's stupid. All right, so GBS, a collection of clinical syndromes that manifest as an acute inflammatory polyradicular neuropathy with resultant weakness and diminished reflexes. And most people seem to know GBS quite well. I see the answers coming up in the questions, so I don't have to belabor this too much. Pathologic mechanism of an antecedent illness and of GBS can be typified by Campylobacter jejuni infections, and we saw a lot of people with, and I say a lot, using that term loosely because we didn't really do any studies, unfortunately. Post CHIKV, we had a number of patients presenting with Guillain-Barré syndrome, a number of patients. The virulence of, so definitely no viral infections are triggers. Immune response is directed against lipopolysaccharide antigens in a capsule of the seed jejudize. So it's a kind of a molecular mimicry that is happening here in Guillain-Barré syndrome. So you have the body producing these antibodies against a particular antigen, but then subsequently affecting its own nerve tissue. Right. This, like as I mentioned there, pathological findings in GBS include lymphocytic infiltration of the spinal roots, peripheral nerves, and hence why the symptoms that you get in these patients, peripheral nerve symptoms you will get in these patients. And you will also get the autonomic presentations. So 2 to 4 weeks post-viral illness. So you'll have the viral infections 2 weeks or 4 weeks before, and you think all is well, and now you start presenting with these symptoms. So it's almost like these symptoms coming out of the blue, and something to note also when patients are presenting, you have to go back and ask, did you ever have the flu? Did you have the flu a week, 2 weeks ago, or 4 weeks ago? And sometimes they don't even recall. Did you have like flu-like symptoms and so on? Important to ask these patients. Because it seems like the disease is coming out of nowhere. Finger and toes, this aesthesia is often wrist and ankles and often as well presents. Some people say this debilitating burning sensation in their hands and in their feet, and it's kind of traveling all the way up. Weakness progresses to involve the arms, strong cranial nerves, muscles of respiration. And so these patients often have to be placed in high dependency units or / ICU because they will develop autonomic dysfunctions, and they will get respiratory failure, tachyarrhythmias as well. All right, and the pain is one of the things that these patients will have. They are in significant pain, and they, like I said, it's neuropathic type pain, autonomic, and I mentioned the autonomic change. Now, these are some subtypes of Guillain-Barré, not for you to memorize, but good to know. And be aware of. You have acute inflammatory demyelinating polyneuropathy, which is the one that you see. That is one that you hear about a lot, and it's common, right? You have acute motor axonal neuropathy. So these tend to have mostly motor symptoms and not neuropathic type symptoms. Acute motor sensors, and these tend to have both motor and sensory axonal neuropathy, but tend not to be as generalized as the inflammatory demyelinating polyneuropathy. Miller-Fisher syndrome. Now, Miller-Fisher syndrome is a special one here because this one, you could, and why I say special is that it will look like myasthenia gravis, meaning it tends to affect the like ocular muscles and the muscle of the face and speech and swallowing and so on. It tends to affect that area. So the face and may have some bulbar type looking signs. And so sometimes it may be missed and it's not missed, but misdiagnosed as myasthenia gravis. So something to note. Acute pan-autonomic neuropathy. So the person mostly have autonomic dysfunction and not the general ascending type of polyneuropathy that you will see. And pure sensory GBS, as the name suggests, right? Again, not to memorize, but to be aware of for sure. Diagnosis typically means clinical. It's a clinical diagnosis, but personally, you may want to do nerve conduction studies to conduct. This will confirm that there's demyelination happening, which you know from your symptoms of burning and neuropathic type symptoms and signs. And lumbar puncture tends to be done in these patients as well. And you're looking to, they tend to have high proteins, suggesting that there's significant inflammation affecting the nervous system in these patients. And like I said, they need to be admitted and needs close monitoring, and the treatment of choice is the IVIG, and you need to support them with analgesia, all right, or analgesics, which tend to be the anti-seizure type drug, the gabapentin and pregabalin and neurobalin and so on. All right. Ooh. So that is that. So that ends that presentation. I don't know if you have any questions from the presentation. I'm going to go now to the answers to the questions. Any part of questions from the what I presented just now? Mostly straightforward, I think. I try to make it just straightforward and to the point. But if you have any thoughts or questions, please feel free to ask. So the first question that we asked earlier, and I think most persons got the answer for this one, right? That is intravenous steroids. Anyone who didn't think that that was the answer? All right, so everybody got that. And the next one here, on the that has normal, she has 4 to 5, the upstairs effects and no plantar response. What is the diagnosis? History of progressive difficulty walking, lower back pain, Yes. So what was the answer for this? All right. Guillain-Barré syndrome. We just spoke about Guillain-Barré. Anybody who thought that was not the answer?
Excuse me, Doc, what was the diagnosis for number one, please?
It was not a diagnosis, it was treatment.
Yeah, but what was the I know, but what was the
Oh,
diagnosis?
the diagnosis. Oh, you mean what was the diagnosis here? 22-year-old woman presents to her physician complaining that her right lower limb had become progressive stiff, clumsy over the past 2 weeks. She is worried about that they need to work that. Tone is increased and there is coolness and wolf, and there is increased sensation in lower limbs with loss of proprioception and vibration sense and pale optic disc. Anyone want to tell me what that is?
Is it MS?
Yep.
Okay, thank you.
Yeah. So within the last 2 years, each lasting for a few weeks. This part. So this part is giving you the answer here. So we talk about presentation of symptoms and signs in time and space. That's it right there. MS. All right. We did that one. Okay, this one, everybody I think got this one. Did it? Everybody get this one? Yeah. Most people, I think some people chose C. I think I saw some C's, but everybody understand why D is the right answer, right? Yeah. Yeah, so we went through that. Fatigability is the hallmark of myasthenia gravis. Diplopia can be seen in a number of other things. Brain stem, stroke can be seen in cranial nerve 3 palsy, can be seen in a number of things, but fatigability, myasthenia. Once you hear that. All right, so this one, and then this one, which one is the most likely to yield rapid symptom improvement? Oh yes, I think some persons may have gotten this one wrong too. Right, so I know some persons chose C, acetylcholinesterase inhibitor. That is a treatment, but guess what? Thymectomy is also a treatment, and guess what? Steroids are treatment. So they are all there listed as treatment. But which one's going to give rapid response? The plasma exchange, because that one's going to remove the antibodies. And so, because in these cases we have crises, you want to do something like plasma exchange, because to quickly remove the autoantibodies and for them to get a rapid response. So the other treatments are treatment that you want to give as well, and a good treatment, but they may not be give it as quick a response as the other things. Yes, Starry.
Good morning, Dr. What would differentiate a myasthenic crisis?
Hold on, I'm not hearing them.
Will you hear me now?
Hearing you. Hold on.
Hello, are you hearing me now?
I'm hearing you now, yes. Go ahead.
Hello?
Yes, I'm hearing you.
Hi. Sorry, what would differentiate a myasthenic crisis different from myasthenia gravis?
Or is the crisis different from myasthenia gravis?
And how would you differentiate between the two?
Or differentiate between the two? All right, so myasthenia gravis is the disease. So the disease is the umbrella thing. That speaks to the crisis, and that speaks to the disease. Right now, for the crisis, where the patient is presenting in a very debilitating condition, so they have deteriorate, or if you want to say that they may present that way initially, but they tend to usually either be on treatment before, not taking their treatment, or there is an insult. So there's a trigger that is causing them to present known as with severe symptoms, often respiratory symptoms. So they are going to have a respiratory arrest in these patients. So it's a severe presentation that requires that they need to be in ICU, admitted in ICU. That's a crisis. So if they are not treated right now, immediately, they are going to die. That's kind of making it very drastic, but yes, that's pretty much what the crisis is about. So they need a treatment immediately. They need to be in a high dependency unit or in an ICU because they are likely in respiratory failure. And like I said, often it's when patients who are on treatment, but either them stop taking it regularly, they decide that they're going to take it once a day, and which is even more common, is that there is an infection. So they got the flu, and they just start a rapid decline thereafter, just can't talk, can't breathe. They generalize, worsening generalized weakness. And these patients, often when they come in, may need to be intubated. So that's a crisis.
Okay, thank you.
All right.
And for this question, if the question had said, which is the best treatment option, then the answer would be C.
Which is the best treatment option? What does it say? Which of the following is most likely to yield rapid symptom improvement? All right. And
Right.
okay, so let me see. On physical exam, bilateral ptosis, which the left affected more than the right is seen. I would choose C. I would say C would be the best option. It's the first line treatment for myasthenia gravis. That's like
That would be the treatment of choice, but because they
Yes.
asked for rapid
Rapid,
improvement,
yes.
it's
What's
going to
gonna
be the
give?
plasma.
Right, because they're creating the context for you for a patient who is coming in crisis. And so in our setting, the plasma exchange is not really available. We just have to kind of just throw everything at the patient. You have to give the acetylcholinesterase inhibitor, we have to give the IV steroids, perhaps, and perhaps patients just need to be intubated until they start responding to the steroids and the acetylcholinesterase inhibitor in our setting. But certainly, where the plasma exchange is readily available and can get that done quickly, then that is what you really want to do to help the patient. But yes, if they ask you which is the treatment of choice for these patients, C would be the answer. And if they point a different way, we talk about the thymectomy and who you do thymectomy in. If they point a different way, where they're giving you some information about, oh, the patient is 40, and when they did a CT scan, they saw a mass, and so on, and they come to you, what is the best treatment? Then thymectomy is your answer. So all these things are treatment options, but it depends on the circumstances. So you want to make sure you're reading the circumstances. Yes, Sean Michael?
Yes, are you hearing me?
I'm hearing you.
All right, just similarly with a question of differentiation, how would you differentiate a myasthenic crisis from a cholinergic crisis?
All right. Well, that one is not easy to do. That is not easy to do because they present the same way. You know, a couple of things that you can use. One is the history. Does have a quick history? This person is known to have myasthenia gravis. Something happened recently. Okay, did the patient stop taking their medication? Or did the patient start taking excess medication? Was the medication increased recently? So there has to be some kind of something in the history that's going to be helping you quickly to determine if you're dealing with a crisis or you're dealing with a cholinergic crisis or a myasthenic crisis. So that's one. Some things with cholinergic crisis is that they may have diarrhea, they may have a lot of salivation, and but they may not have that either. But that if they do have that, that's symptoms of diarrhea, salivation, lacrimation, those kind of symptoms, then they clue you into that this is a cholinergic crisis. But I think your best bet is your history. That's going to help you. So finding out what something changed with your medication recently. Did the patient get an infection? Did start having flu or a pneumonia? Pneumonia tends to be a trigger for these patients. Or were they placed on any antibiotics recently? There are some antibiotics that will trigger, will make a myasthenic patient worse or cause them to decline, things like quinolones. So your history is going to be a very, very big part of you making a decision about whether this has been a cholinergic crisis or a myasthenic crisis.
Okay, thank you.
Yeah. All right. So that's that one. Let's go to the next one. So this one, I think everybody had gotten this one. I think so. Let's see what it says. Yeah, everybody has gotten that one, right? I believe so. And the next one, for this one, oh yes, no, this one, some people got this one wrong. I think most people got this one wrong. And so I'm gonna get some things about this one. All right, so why do you think that is the answer? Or what would most people choose here? Was it A or was it C? A, yes, I think most people chose A here because you're thinking that this person has what?
Is it that he has GBS and he could possibly go into respiratory failure, so we need to intubate him?
That's exactly it.
Okay,
that's exactly it. Right? And that's why I mentioned about the GBS patients. Want to monitor them closely, want to watch them because they will go into respiratory failure. All right, so IVIG is my first choice, my first line treatment for these patients. IVIG, I want to get it fast and get it as soon as possible. I want to treat them. But why is it the first thing I want to do in this case? Okay, looking at when you have a questions and they give you the information, they're giving information for a reason. Look at the information and say, why are they telling me this? Okay, is it a distractor or is it to help me? And they're telling you to help you. The CSF results, not so much here and there. If I already by now know that, oh, this is like a GBS, right? But this is what is the help, is the clincher here. The spirometry is performed. What are they telling me? And it shows a forced vital capacity of 0.85 liters. And they get a normal here of 4.8. This patient is going into respiratory failure very shortly. Right? So giving him IVIG at this point is not going to save him. I need to intubate him now. Right? So that is some of the things that you want to look for in an MCQ. Right? But yeah. So I think this one got some persons. This question, I think most people got this too. What was the answer? Yes, Guillain-Barré. Nobody had any problems with this? No? So you see the autonomic dysfunction being spoken about in this one in terms of presentation, weakness in lower extremities and palpitations. Why did you tell me about palpitations? Autonomic dysfunction. When we talk about tachyarrhythmia, this patient didn't get them? Yeah. Guillain-Barré. And part two, then part two becomes very easy. All right. Oh, there's another question. Okay, this question. Everybody got that, right? Should. And like I said, in terms of looking at differentials, they gave you the answer really, because they told you that patient had these skin lesions. You know, they call them Gauthron's plaque or papules. Yeah. And where do you find Gauthron's papules? Mathematics. What else can it be? Excuse me. Right? So that is that. So any other questions?
Excuse me, Doc, could you go back to the previous question, please? Not the last
This one? No, that
No, the one
not the
before.
last one, the one. This one?
Oh, yes, thanks. Oh, yes, okay, all right, thank you.
All right.
Hi, Doc. Just wanted to clarify something. Earlier in the section, you were mentioning transverse myelitis. Would you be able to just quickly distinguish how we can rule it out as a differential?
All right, so transverse myelitis. I really should put this in this presentation, but there's so many things. So transverse myelitis is a part of the NMO spectrum disorder. NMO-SD they call it, right? NMO spectrum disorder. This you should be aware of, right? And like I said, it presents very similarly to multiple sclerosis. So how do you differentiate it from multiple sclerosis, you're asking?
Yes, no, just distinguish it.
Just generally, okay.
Yeah,
right.
but
So for multiple sclerosis, right? I'm sorry, transverse myelitis. So the patients may also have optic neuritis. The patients may also have they will have is that when you do the MRI of the spinal cord, you will see a long segment of the spinal cord being hyperintense or being affected. You don't see that in MS. In transverse myelitis, it's called a longitudinal extension of the spinal cord lesion. So it spans over about 3 or 4 lumbar spine area. In MS, what you find is that there are patchy areas of hyperintense lesions in the spinal cord, and you will also when you do the MRI brain, you will see those areas in the brain where these hyperintense patchy areas in the brain as well. Not typically so with multiple sclerosis, but transverse myelitis. So you tend to have this long extended area in the spinal cord, hyperintense lesion in the spinal cord in transverse myelitis, and that does differentiate it. If you see that on the MRI, you are dealing with NMO spectrum disorder until proven otherwise. But that is what that proves is not multiple sclerosis. Again, if it's the presentation as well. If the patient tells you that the symptoms started and stopped, so this relapsing and remitting, you are likely dealing with MS and not NMO spectrum disorder. For a person with animal spectrum disorder, they tend to present with transverse myelitis more so than because transverse myelitis in itself is a part of the spectrum of animal spectrum disorder. So the person will have transverse myelitis and they must have optic neuritis as well for you to be considering this to be animal spectrum disorder. For multiple sclerosis, they don't need to have transverse myelitis. They can just present with optic neuritis. And again, with the criteria that we show you, the McDonald's criteria or the updated McDonald's criteria, revised McDonald's criteria, they call it, then you want to be looking at that. All right, there is a criteria for an animal spectrum disorder as well. I believe it is called the Wingerchuk criteria. Wingerchuk criteria is a criteria that is used for normalitis of the animal spectrum disorder. And another thing that distinguishes it is the aquaporin 4 antibodies. So like I said, sometimes for years, some of these conditions have been mixed up and persons were misdiagnosed with one or the other, right? The treatments differ in those, so it's important to differentiate between the two. But those are some of the ways that you can differentiate them.
Okay, thank you.
I hope that was helpful. Peter, you're there confusing more.
No, it's okay.
Yes, so that is one other thing. Wingerchuk criteria. Have a look at the Wingerchuk criteria. So there is a criteria also for animal spectrum disorder, right? And the aquaporin 4 antibodies big in differentiating between MS and animal spectrum disorder. That's big. And in terms of the presentation, if you have a remitting relapsing pattern, it's not likely to be animal spectrum disorder. It's likely to be MS that you're dealing with. If you do the MRI and you're noticing that the pattern is a longitudinal extension of the hyperintense lesion in spinal cord, you're dealing with MS. You're dealing with animal spectrum disorder, transverse myelitis, as opposed to MS. All right. So I think looking at the Wingerchuk criteria may be helpful for you there as well. For those who are wondering how that is spelled, Wingerchuk, it is Wingerchuck. All right, any other questions?
Yes, Doc. Earlier on, you were mentioning how to differentiate between polymyositis as opposed to dermatomyositis, and you mentioned the skin involvement. You also mentioned one other distinguishing feature I didn't quite get. Could you just repeat that, please?
For polymyositis and dermato?
Yes.
Oh, no, it wasn't between dermato and polymyositis. Dermatomyositis is easy because you have to have skin involvement. You don't have the skin involvement, that's not the diagnosis. Just move on to something else. Because dermatomyositis, by definition, is that there is skin involvement, right? But the polymyositis, I think what I was saying in terms of muscular disease or neuromuscular disease, polymyositis and dermatomyositis are differential diagnoses, and they tend to present with proximal weakness as well, right? So when you're looking at differential diagnosis, so you're in an OSCE and you examine a patient, and you find that the patient has rolling weakness and they have more proximal weakness than distal weakness. Polymyositis may be a differential you want to mention. Dermatomyositis may be a differential you want to mention as well. What's his name? Myasthenia gravis and the differential you want to mention as well. But then when you ask, well, how do you differentiate between the two? Dermatomyositis has skin signs. Guthrun's papules is one source. The Shaw sign is something else. The heliotrope rash is something else. And if the person doesn't have any of those things, dermatomyositis is not your diagnosis. Polymyositis, you may see these patients may have tenderness, pain in your muscles, right? But let's say 100% of the patients don't have pain, right? So it's one of the things that you will see in somebody who has polymyositis, that they have tenderness of the muscle groups. But they don't want to say, okay, use that as a thing to say, I am diagnosing that. But you may find that they have tenderness of muscle groups. But if they don't, maybe you want to consider, is this myasthenia gravis and so on. So that's the point I was making.
Thank you.
Does that help?
Doc, sorry, one last question from me.
Sure.
Option D, the pyridostigmine that can use to treat and diagnose MS. Sorry, myasthenia gravis.
To treat it?
Yes, Doc.
Yes, you can. You can use it because it is a acetylcholinesterase inhibitor. Yeah.
Okay, but for the test, you can use it to investigate for it too?
No.
No.
Usually if you're
Okay.
investigating for it, it is going to be you're going to use the hydrophonia as short acting.
Okay, that's for the 10. That's part of the
Tensile,
10.
right? Yes.
Okay, so it's the all right. Thanks. I was mixing them up. That's right. Thank you.
Right.
Hi, Doc. That's a question. But do you have any tips for the exam on Monday and Thursday?
On Monday is
Nearby.
medicine?
Well, it's a unified exam now, so yeah.
Oh, yes, you're going to get medicine. Well, the one benefit of the unified exam is that you get less medicine question. But that's one thing. Say that when you get a whole college medicine question, so they can't ask you, there's not a whole scope that they can ask you on, but they don't, the drawback is that, I guess with any exam, you don't know what they're going to ask you. Is read the questions. For those persons who have the session with me on approach to MCQs, read your question. Do not assume what they're asking you from at the start reading. Read your question. And let me use one point here. One question in point is the one on the where intubate the patient instead of giving the other treatment. They are giving you some information for a reason. So look at the information that they're giving you and ask yourself, why am I getting this information? How is this helping me? Right? Very important. So read your question, understand what they're asking you. Do not take a long time on any question. Do not leave any question unanswered. Do not leave any question unanswered. If you don't answer the question, you can't mark, and they don't take marks from you if you get it wrong. So don't leave it unanswered. Another thing that students do, please do not go back and change your answer for a question that you have no clue what the answer is. Leave it alone. Chances are your first answer is the correct answer. Okay? It's your first gut feeling. So don't change it if you really don't know the answer. Just leave it and move on. Right? And I had some students who confessed that that is probably why they fail, because they keep going back and going over and cheating and say, oh, maybe it's this, oh, maybe. If you find yourself doing that, you don't know the answer. Just go with your gut feeling, which is your first answer, and just stick with it and move on. Right? What else can I say? No key points. Key information. Also, diseases present. Side effects of medication. They like to ask that in MCQs. Side effects of medication, but they don't ask you what is the side effects of medication. They don't ask you that. They will give you a case and then they say, what is the likely cause of this patient's presentation? Right? And this is a side effect of the drug. So you need to be aware that they're asking you a side effect of the drug. That's why they're going to give you a list of drugs. They're giving you that for a reason. Right? So you look out for things like that. What else? Yeah, and then look out for things like best answer. So the other things are answers. And we saw that in this question where thymectomy, steroids, IG, they are all answers. But what is the best one? There's a reason they're asking for the best one, because they give you some information to tell you which answer they want. So like in that question, they told you that the patient's FVC is 0.85 liters. If they didn't give you that piece of information, then the anticholinesterase would be the choice. That's the answer, the drug of choice, right? But no. They gave you the information to tell you that this patient is impending respiratory failure. So intubation becomes the best answer for that question. So things like that you want to be looking out for. And remember, they're not trying to trick you. So don't think that, oh, he's not trying to trick me. No. They're not trying to trick you, right? We are trying to get you to think critically. So, and I say we, but I didn't say the people. But that's generally what the idea is, to try and get you to think critically. And it's not anything unusual. And I've seen MBBS paper. I've not seen this one in particular, but I've seen MBBS paper. It's things that you would have seen. It's not anything unusual. It's not the same heart failure stuff. Ischemic heart disease things. Is it pulmonary embolism? Is it this diabetes, hypertension? It's nothing unusual. And for the neurology type questions, stroke. We are doing a stroke today, but stroke is one of those things that will come on the paper as well, because that's so commonly seen. An hemorrhagic stroke and things like that. And yeah, these ones that I present here, MS will come, rheumatology, you may have a couple, 1 or 2 rheumatologists, things like lupus and rheumatoid arthritis, are things that you want to look out for as well. Yeah, but you're not going to get anything unusual. Know your drugs and know your side effects, what they are used for. Know the generic name of drugs. They don't put brand names in the MCQ. So if you use, I remember some years ago, some students, what was it? A drug? I think it was the Jackson, one of those drugs, and they used the brand, the generic name, and the students didn't know what it was. So you have to, so remember it, you want to make sure that you know the generic name of drug. Yeah, I think that's the best I could say. And don't be too nervous. If you're nervous, you do nonsense. So try as best as possible to relax and do as many MCQs as you can, and use the MC at this stage. Do not read. At this stage, do MCQs and use the MCQ to tell you what your knowledge looks like. No. And then based on the MCQs that you're, based on what you observe your knowledge to be, you adjust, you go and make up for it. So if say you do a question and you realize, oh, I got this question wrong. Why did I get it wrong? Oh, I thought that was the first line drugs. Okay, so I realize, oh, that was a gap in my knowledge. So let me just go read that little bit of blur back in my textbook, right? Things like that. So do not be reading at this stage. Make sure you have your hands on some MCQs like this, case-based MCQs, and do them. And that's how you prepare for the exam. Before the exam, make sure that you sleep. Now, listen to me. You are all physicians there, yeah? Now, if you are tired, you cannot function at your maximum. Even if your brain wants to think of something reasonable for an MCQ that you don't know the answer for, it can't, because it's so exhausted. So you want to make sure that you rest the night before. Do not be staying up until 2 o'clock when you're doing any questions and whatnot. Don't do that. You're going to put yourself at a disadvantage. So if you're in the end of the exam and you want to think through something, you're going to be so exhausted, you can't think it through. So be rested. And some people are going to say, you can't stay there, that's a God. Now no, really trust me. You know more than you think you do. But you need to give yourself an opportunity to put that forward in the exam. If you're exhausted, you're not in the best condition to do so. So make sure you're not exhausted. All right. Yeah, and make sure you're working with a partner at this stage too, because somebody else might know something that you don't know, and instead of you reading it, person just tell you. So that's another way to gain knowledge as well. So have at least one other person that you're working with, and not wasting time. Right? You're kind of giving each other knowledge and building each other's knowledge. Yeah, that's what I would say. All right, anything else? Hope that was helpful. All right, so all the best to you and take care. All right.
Thank you.